I think we shall now go on to our next speaker. Our next speaker is our very eminent teacher of excellence, Dr. Ramanjit Sihota, and she is going to be telling us beautifully all that we need to know about the anterior segment OCT interpretation and the technique which would help us further in the diagnosis and management of glaucoma.
I would like to say that I'm trying to share my thing. Has it?
Yes.
Yeah. Okay. All right. I'd like to say that I think Tanuj's talk is the most important one for postgraduates, because that is something that all of us should be doing, ideally in all patients, but definitely those in whom we think there may be glaucoma. Can I be heard?
Yes.
Yes, ma'am, you're audible.
So basically, the reason that we think about an anterior segment OCT today is that it is non-contact as compared to the gonioscopy. It gives us really high resolution images, and it doesn't need Dr. Tanuj to be doing a test. Any technician can do it. So it's an easy non-contact high resolution image, which gives us some indication, both qualitative and quantitative. The qualitative one is to look at the general anterior segment morphology, more specifically at the iris configuration, any iris abnormalities there might be, and of course, most importantly, the iridotrabecular angle. As far as quantitative is concerned, it gives us the biometry of the entire anterior segment in terms of thickness of the cornea, anterior chamber depth, the anterior chamber width, area, volume, anything you like, you can get from this. It specifically looks at angles depending on where you measure the angle. And as I said, it also helps us with the central corneal thickness. But when we think about what are its clinical uses in glaucoma, I think we talked in two general sort of spaces. One is the management of glaucoma, and the second one is how has it helped us in the research in glaucoma. So as far as management is concerned, just like gonioscopy, basically we're looking to see how does it help us in diagnosing different glaucomas. And just a few examples to also say that the whole idea of doing any investigation in glaucoma or a patient with raised IOP is to see what is the cause. Why is the IOP on the higher side? So if you can see this image on the upper left-hand side, this is what a normal anterior chamber would look like. These areas here that I'm pointing to are the scleral spur. This actually is showing us a beautiful trabecular meshwork, and this is what Tanuj was trying to show us as the corneal wedge. So the corneal wedge is actually where the trabecular meshwork starts, and you can see this, and you can see the space of the trabecular meshwork behind it. This is the line joining the two scleral spurs, and by and large, the lens tends to be either behind or just a little bit anterior to that. I will come back to that in a little while. When we actually have the high definition images that are now available with swept source OCT, you can see that the anterior, the entire trabecular meshwork is visible. And there's this little black line over there, which was originally called the trabecular shadow, but has now been labeled the extracanalicular limbal lamina. So this is what I've drawn over here. And if you look at this diagram, you can see the lamina over there. At the same time, you also see what is called the trabecular scoop. That means here we have the scleral spur, and this is the space available for the trabecular meshwork to be sitting on. So going back again, I think the most important the tool we have with anterior segment OCT in glaucoma is to identify the scleral spur. And there are very many ways in which it can be done. I'll talk about a few. One is that you can actually see where the trabecular meshwork ends, and you can see that there's a kind of little point over here. So this is the scleral spur. The other way to do it is to actually see the anterior surface of the ciliary body. If you see the anterior surface of the ciliary body and follow it further up, that is a secondary sort of indicator of where the scleral spur should be. Now, if you look at these images, these are nice and open. On the other hand, you can see this is a much narrower image, but again, you can see the entire trabecular meshwork shown to us in great detail in these high definition images that are now available. So what are our basic aim, as Tanuj said, to start with in gonioscopy? You want to know, is the angle open or is the angle closed? So in the previous one, I showed you an open angle. This is wide open. There is absolutely nothing that is sort of in contact. The iris is not anywhere in contact with the cornea or the trabecular meshwork. And exactly what he said is, you can see the last roll of the iris, the ciliary body, and then you start to see the posterior trabecular meshwork, anterior trabecular meshwork, and the Schwalbe's line. So if we are looking at a narrow angle, and this is what we would say is a narrow angle, this is what we can see clinically. You can use a Van Herrick's, you can use a torch, you can see anything clinically. This is the kind of picture you're likely to get on the anterior segment OCT. And you could, if you like, make it colored. It just looks nicer, but doesn't give us anything extra. So when we actually see these narrow angles, what are we actually aiming to do? We would like to get a measurement of the angle itself. This is from the scleral spur. You mark the scleral spur, and most of the anterior segments will automatically give you what is the angle between the most peripheral part of the cornea and the tangent drawn from the surface of the peripheral iris. You can additionally get an angle opening distance, which can be at 500 microns, at 750 microns from the scleral spur. It again gives you areas that are there in these 500 or 750 microns from the scleral spur. So in all these cases, you actually have to mark the scleral spur. And in these images, you can see it, but in a significant number, it is not so easy to see. Again, it's the angle and then any additional measurements you want to take, which are available. These are not so much of clinical significance. This is really, the angulation is of clinical significance. Anything less than 20 degrees is likely to be occludable or closed. So in primary angle closure disease, you can see that the scleral spur is here. This is the red dot, which is showing us the scleral spur. And you can see how much iridotrabecular contact there is. And in the Cassia machine, you can actually see how extensive the iridocorneal or iridotrabecular contact is. Up to here is the trabecular meshwork. Anything beyond that is the cornea. So you can see extensive synechia that are there, and it tells you what is the extent. In other glaucomas, in congenital glaucoma, you're likely to see a thin iris. You're likely to see abnormal tissue, and you can see the abnormal tissue here in the angle, as was shown on the gonioscopy. You can see patients who have spherophakia, and you can see that there is a secondary angle closure in such eyes. You can see that there are patients in whom there is a synechia which is formed either to the intraocular lens or to the lens itself. And this leads to a secondary bowing of the iris and angle closure. You can get silicone oil, which you can actually see beautifully sort of layering the back of the cornea, and therefore you know it's also layering the entire extent of the trabecular meshwork. In PKs, you can see that there are extensive synechia generally to the host graft junction, and this is the host graft junction, and you can see the iris synechia over here, and therefore you know that this is what's going to be to continue to be there even after you do your management. In aphakic glaucomas, remember, you can have an open angle with aphakic glaucoma because of chronic uveitis and other reasons, or a developmental anomaly that may be there with a congenital cataract. On the other hand, you can have synechia which form to the vitreous face or to the IOL or to a membrane that might be there, and therefore you get a secondary angle closure. So you use this to diagnose glaucomas or the causes of the different glaucomas that are seen. It has helped us greatly in diagnosing the reason why angle closure occurs in a particular eye having primary angle closure disease. I think we've all seen pictures like this, wherein when there's light, there's meiosis and the iris is pulled centrally. The moment the patient goes into the dark, you can see the bowing of the iris and the angle closure. So if we actually look at different causes, the first thing you have to say is that an occludable angle would be one which is less than 20 degrees. So the angle formed by the most peripheral cornea and the iris If it's less than 20 degrees, is likely to go into closure. A plateau iris is one where you have a flat iris which suddenly dips in the periphery. Because this is an anterior segment OCT, you cannot see that the ciliary body processes are actually pushing up the peripheral iris. This is a controversial one, and I think we saw this diagram on the right side earlier, where if you join the two scleral spurs, the lens is generally at or just slightly ahead of that. As compared to that, a lot of angle closure eyes may have much thicker corneas, and it's thicker lenses. And it's the reason why the lens is thick is because the width of the limbus, that means from limbus to limbus, it's much smaller, and therefore the lens is allowed to become thicker. And here you can see that the lens is actually more than 1/3 of the distance between the a line joining the posterior cornea to the line joining two scleral spurs. So this is seen probably in about 10 to 15% of patients with primary angle closure glaucoma. Plateau iris is seen in probably about 5 to 10% of primary angle closure disease. And please remember that relative pupillary block is the most important cause. The second thing, as Dr. Tanuj was saying, is we want to be able to differentiate apposition from actual synechia. So if you look at these pictures, you can see I've drawn a white arrow and I've drawn a red arrow, and you can see that the white arrow is actually just a bowing of the iris, and you cannot see the extreme periphery, and there is still a very narrow recess which is open. This, when looked at gonioscopically, very often looks like apposition. On the other hand, when you have actual synechia, you can see that the surrounding tissue, that means the cornea, also is showing us fibrotic changes over there. And the anterior segment OCT helps us to actually differentiate these two much better than we possibly could on gonioscopy. The ITC index I've already spoken about, but basically just to reiterate, what it actually does is it helps us to know how much of the iris is actually touching the trabecular meshwork. And this is a patient with primary angle closure, and you can see there's just a little bit of the iris which is actually touching the trabecular meshwork in both eyes. All right. And this is in the with the patient in the dark, and this is with the patient in light, and you can see the difference that there is. This is a patient with primary angle closure glaucoma, and you can see again, please, if you look at the iris touching the cornea, you can see the associated sclerosis, fibrosis that is in the angle and in the cornea and the trabecular meshwork as well. And if you look at the ITC, you can see almost 360 degrees of the iris is touching, definitely touching the trabecular meshwork and probably into the cornea. So the ITC index has helped us to say what is the extent of the pass, and therefore if the extent of the pass tells us what is the damage to the trabecular meshwork. If we want to evaluate the anterior chamber in opaque corneas, one, as I've already said, is in post-PK glaucomas. Here we have a patient who is a Peters anomaly, and this was an anterior segment. It was actually an UBM, but you can do a similar one with an anterior segment OCT, which actually shows you what is happening. And post-surgery, you can see the clearing that is seen. So I'm sorry, in children, we find it a little difficult to do an ASOCT, but it was just to tell you that this evaluation can be done. Intraoperative assistance these days is quite useful, especially when we are doing blebs like this, which need to be revised. It actually tells you what the bleb looks like and helps you to remove just the epithelium so that what is left is a functioning bleb. It can also be used in surgery itself, and it has been said that if we use an intraoperative anterior segment OCT, we can determine the thickness of our superficial flap and also the size of the ostium. Finally, I think to evaluate therapy is quite important in management. It tells us whether the iridotomy is patent or not. It tells us what is happening to eyes once an iridotomy is done. So you can see over here, again, this is the ITC, and you can see only about sort of 20 degrees of the iris is actually touching the trabecular meshwork. This is a patient with primary angle closure glaucoma, and you can see the angle is narrow, but not showing us any synechia. After an iridotomy, this is the iridotomy that has been done, you can see the decrease in the iridocorneal touch that was there. Okay, so you can see that there is the iridotomy has helped. Similarly, if you were to see this patient, you can see that again, after the iridotomy, there's absolutely no iridocorneal touch that is seen, even though you could see it earlier before the iridotomy was done. In primary angle closure glaucoma also, as I said, we can see almost 360 degrees having a significant iridocorneal contact. And once the iridotomy is done, you can see that even that has decreased significantly. Anything that was above the trabecular meshwork has come down. You can see the difference pre and post iridotomy. So an iridotomy definitely seems to help. And this helps us to evaluate the therapy and say that in such an eye, possibly medical therapy may be a good option and surgery may not be required. What about research? I think, as I said, it's helped us to understand pathogenesis. It's, I'm sorry, we're still going on with the filtering bleb at the moment. The other thing is to actually grade a filtering bleb, and you can see it tells us what is the thickness of the wall of the bleb. It tells us whether there are any cysts. It also tells us what is the size of the ostium that we have made. And these photographs are 1 year, 2 years, 3 years after surgery. So you can see that these kind of cystic spaces probably lead to a dysesthetic bleb. They may be leading to lower IOPs, but the patient is going to be quite uncomfortable. This is a much more sort of gradual sort of rise in the contour of the bleb and is less likely to cause problems as far as the patient is concerned. What we also see is that you can see post-operative complications that may occur when we're doing trabeculotomies. This is a Descemet's membrane tear, sometimes even with trabeculectomy. Drainage devices can be seen very clearly. You can see the AGV tubes over here. And if you put it into the pars plana, you can see the tube coming behind the iris. You can see an express shunt, and because it's metallic, you can see the edges much more clearly. It tells you that in this particular instance, the express shunt has been blocked by fibrosis. Once you do a bleb revision, this is the pre-operative picture of the anterior segment OCT and the color photograph. And you can see it after a bleb revision has been done 4 years after the surgery. So you can see there's still a filtering bleb, and you can see that the patient had an IOP of 10 to 12 millimeters. So coming to the research, beyond the parameters that I told you about, there are many other parameters that are being evaluated. And as I said, the angle is what we are most often measuring, but you can measure anything else in the anterior chamber using the various tools available, including the area, the volume of the anterior chamber, the area, the volume of the iris, when it is constricted, when it is dilated. So all of these are giving us a good indication of what is happening inside the eye physiologically. So all these measurements can be done and should be taken care of in research. So some of the anterior segment biomarkers that have been suggested for glaucoma after all this research is that in congenital glaucoma, you can see that there is a maldevelopment of Schlemm's canal. It may not be there at all. There may be an associated membrane, very similar to the so-called Barkan's membrane seen. In angle closure disease, people are now talking about the anterior chamber width and area and the iris area being more predictive of which eye is actually going into angle closure. Finally, the trabecular area and morphology has now become so well visible that it's almost like doing a histopath of the angle. So I would like to say that, anterior segment OCT is not essential in the clinical management of glaucoma, but it is helping us in many ways to understand more of the pathology and the management or better management of whatever we are doing, because it gives us pre-operative pictures and post-operative parameters that actually help us say, this is the surgery I did, this is what I ended with. The IOP is not as low as I want it to be because the bleb is probably not showing me as many microcysts as I would like. So you can change your surgery depending on what you see on the anterior segment OCT. It is also suggested that you can use an anterior segment OCT at 1 month after surgery, and that would help you to decide, no, this patient needs additional mitomycin C or it needs additional steroids, or you can stop the steroids, or you can do some needling for the bleb so that you get good long-term results with your trabeculectomy. So I'd just like to thank everybody who was involved in this presentation. Thank you.
Thank you very much, Dr. Ramanjit. Many of the questions I had wanted to ask have been answered in your presentation. But again, like just taking an example, maybe a young patient with an aniridia where you cannot do a gonioscopy, there are certain areas where anterior segment OCT actually does help, like rather than just being a secondary tool, even in the primary diagnosis of an angle closure or cross.
Yes, absolutely. I think the most important place is when there is a corneal edema or there's corneal opacification. At that point in time, you don't know what you're going into. You know the pressure is high. You know the baby has a corneal edema, and for years we used to just go into the eye saying, "I hope there's no aniridia there." But now I think we can actually figure out before we get in whether it's an aniridic patient, whether there's an anterior segment dysgenesis, whether the angle is showing us very severe problems, and in things like post PK, post adherent leukomas and things like that. Again, it helps us to say, there is a adherence between the iris and the cornea in this quadrant. I should avoid that quadrant and probably do my surgery or any filtering surgery away from any of the already existing adhesions.
Thank you very much, Dr. Ramanjit.